Merry Christmas, friends. Pradeep Pendyala, Professor of Anesthesiology at Asram Medical College, Eluru city of Andhra Pradesh, India. Dear friends, I wish you all a very happy and Merry Christmas. Today I am going to talk about something very interesting, that is post-operative complications after thyroid surgery. Friends, everybody would talk about recurrent laryngeal nerve injury and thyroid storm and many things else. By the way, I would also tell you something more about recurrent laryngeal nerve injury as well as more and more about superior laryngeal nerve injury, which rarely people talks about. Before that, I would love to tell you something more interesting, that is occurrence of hypoparathyroidism after thyroidectomy. Yes, friends, around 20% of patients undergoing thyroid surgery can end up with loss of parathyroid glands, causing severe hypocalcemia. I'm sure you people know that normal levels of calcium is around 8.5 to 10.5 milligram deciliters. And if it comes down after parathyroidectomy to less than 4 milligram per deciliters, that would definitely cause hypocalcemia features. That can be definitely detected by lab testing, but clinically you can be assured that you can do very simple 2 tests and come to know that it is nothing but hypocalcemia. What are they? I am sure you must have heard about Chvostek sign. Friends, it is not Chvostek, it is CH is silent, it is Chvostek sign. Chvostek sign is nothing but tapping on the face 2 centimeters in front of the external auditory meatus, just in front of the tragus, just tap with your finger so that one of the branches of the facial nerves gets stimulated and there will be muscular twitch on the face, on that particular part of the face. That is positive sign of hypocalcemia and that is known as Chvostek sign. Next is Trousseau's sign. Trousseau's sign, again many people say it is Trousseau's sign, it is Trousseau's sign. It is very simple. Inflate the blood pressure cuff around 30 millimeter mercury more than the expected systolic blood pressure and leave it for 3 minutes. There will be carpopedal spasm on that side of the hand. Carpopedal spasm is indistinguishable and you can easily make out what it is, and it is nothing but a sign of hypocalcemia. Friends, that's for the thing. And the other thing which I just mentioned, recurrent laryngeal nerve injury, if it occurs, there could be dysphonia continuing after 6 months also, when there is a permanent cutting, ligation or cauterization of that nerve. Bilateral recurrent nerve injury is much more serious because both vocal cords may assume a median or paramedian position, causing airway obstruction, stridor, and that could require tracheostomy. That's dangerous. At least immediate intubation has to be done. Accidental transaction commonly occur at the level of upper 2 tracheal rings, where the nerve closely approximates the thyroid lobe in the area of Barre's ligament. That's how it takes place. By the way, I had just mentioned about thyroid storm. That also occurs especially in people who had not been well controlled and there is some element of hyperthyroidism in that. Or the tissue remaining after partial thyroidectomy, that can liberate thyroxine and cause thyroid storm, which is characterized by hyperpyrexia, tachycardia, altered consciousness that could be in the form of agitation, delirium, coma, and also hypertension. Friends, thyroid storm is a medical emergency. You have to treat it aggressively, and they could be hypothermia, and don't get confused with malignant hyperthermia. It is thyroid storm. This also produces hypothermia, but unlike malignant hypothermia, thyroid storm is not associated with muscle rigidity, elevated creatine kinase, or marked degree of metabolic lactic acid and respiratory acidosis. Treatment, you have to give care of temperature control, hydration, cooling, and esmolol infusion. Another method is intravenous beta blockers with a target of maintaining heart rate below 100 per minute, and propyl thiouracil, very high doses to the tune of 250 to 500 milligram every 6 hours orally or by nasogastric tube, followed by sodium iodide 1 gram intravenously over 12 hourly. This is very important to control thyroid storm. So, talking about various other problems which can occur, I just mentioned about other problems after thyroidectomy, that is tracheomalacia. If a large size goiter compressing over the trachea for a long duration, it can cause pressure atrophy and erosion of the cartilaginous rings. So, immediately after extubation, the entire trachea collapses, and that can cause severe respiratory obstruction. That's again an emergency which needs immediate intubation. But how to know that this can occur? It's very simple. Whenever you are doing this test, post-operative respiratory dynamics can be seen when you are withdrawing the tube, and you have to deflate the cuff. When you deflate the cuff, and there will be a problem in ventilation, that is the indication that the patient is likely to go into tracheomalacia problem after extubation. That is known as cuff leak test. You have to retain the endotracheal tube and deflate the cuff and see whether any leak is heard or not. If the leak is not heard, that means cuff leak test is positive. So not necessarily that extubation will definitely lead to tracheomalacia, but you have to keep your antenna up. You have to be cautious that this particular case can lead into this problem. And I just mentioned about superior laryngeal nerve damage. Friends, very few people know that this is also very common along with recurrent laryngeal nerve injury in laryngeal thyroid surgery. There are two parts. It can be resulting in paralysis of the cricothyroid muscle. How? Superior laryngeal nerve can be damaged in 3 to 5% of thyroidectomy procedures. Normally, the injury occurs in the external branch of the superior laryngeal nerve. That results in paralysis of cricothyroid muscles. In other thing, if the injury occurs in the internal branch of the superior laryngeal nerve, which provides sensory supply to the mucosa of the supraglottic region of the larynx and superior surface of the vocal cord, that results in dysphagia in that particular patient. I'm sure this was very, very informative, friends. Thanks for patient listening. Once again, Merry Christmas. Bye bye. Take care.